Firstly, I'd like to thank the organizing committee for inviting me to this conference. It's a great honor and a great pleasure to be here to meet, friends that I've made over the years again. I am going to talk a little bit about the role of potassium and salt substitution in the management of hypertension. This is my disclosure. Now, we know for many, many decades, the leading causes of death in the world is ischemic heart disease and stroke, the non-communicable cardiovascular diseases. This, of course, was a little bit of an anomaly because it's the latest data I could get, is that in 2021, COVID seems to have come a little bit higher than stroke, and we know the reason. It was because of the pandemic. But of course, it is a communicable diseases, while the others are non-communicable disease. Be that as it may, the biggest driver of this death is hypertension. Hypertension is a major cause of death worldwide, far more important than the cholesterol, physical inactivity, obesity, smoking, and so on and so forth. And that is partly because of the prevalence of hypertension. Looking at the world map of hypertension, the darker colors are areas of high prevalence, the lighter colors are lower. Overall, the prevalence of hypertension in the world is around 34%. We saw earlier Kazakhstan has 32, so that is about the correct figure. But what is worse is that the majority of them live in low and middle income countries. And of course, basically, this is a lot of Asia and Africa. Be that as it may, if we look at the map of the salt intake, where the dark blue signifies lower salt intake of less than 5 grams, which is the recommended amount that WHO says we should be taking, versus the darker colors of green, orange, red, where it signifies a higher salt intake of salt per day. And we can see again, except for Africa, the salt intake in the world is rather high, very high in Asia, Southeast Asia. So much so that the global mean of salt intake is around 9 to 12 grams per day, depending on which region you come from. Now, I would like to share this in China because it comes from China, and so something that you should be very proud of is that the relationship of salt and hypertension is not new. It's not something that's been discovered in this century or the last century, but it was discovered or noted way back in 600 BC by the Yellow Emperor, who in the classics internal medicine stated, if too much salt is used in food, the pulse hardens. I think this suggests arterial stiffening. Tears make their appearance, probably the aneurysm and the rupture hemorrhagic stroke that we get. And the complexion changes. I think this signifies the sallowness that we get in the end-stage renal disease. And certainly more modern times have tested this hypothesis about increased sodium intake. And indeed, in normal tensive individuals, if we load them with more salt, the higher the salt, the greater is the rise in blood pressure. And it is quite significant with the huge loading of sodium. The blood pressure can go up by as much as 30 millimeters of mercury. And then, of course, that is only blood pressure. Does it make any difference to cardiovascular events? Indeed, it does. And this is a Finnish study that looked at people who were taking the amount of salt. And what was found is for every 100 millimoles of increased salt intake, you increase your risk of coronary heart disease, cardiovascular death by 45 to 50%. So this is huge impact in terms of eating extra salt. And this is what we are doing. We're eating more than the 5 grams, and therefore this is where we are increasing our risk. The good news, of course, is if we lower our salt intake, we can lower blood pressure. And this comes, of course, from the very famous DASH study that showed that with lowering of salt intake, whether you are on a low, intermediate, or high salt diet, you do get reduction. But the best reduction is seen in people who are on a high salt intake of about 8 grams or more. And this applies to all of us. All of us are taking more than 8 grams per day. And with lowering of salt intake, we can lower blood pressure by as much as 6 millimeters. And this would be equivalent to taking a single low-dose monotherapy for antihypertensive. So this is very powerful reduction just by reducing our salt intake. And so WHO, in recognition of the cardiovascular disease being the leading cause of death in the world, recognizing that high salt intake is happening all around the world. They set in 2013 9 global targets to reduce NCDs by 2025, which is next year. And basically, the target was to reduce prevalence of hypertension by 25%, reduce salt intake in the population by 30%, and we are not going to achieve that. No country has achieved that and is likely to achieve it in the next few months of the year. But then we need to ask ourselves whether sodium intake is the only story. And that's because data has emerged that has shown us about the relationship of potassium with blood pressure. The INTERSALT study, again a study that's been done nearly 40 years ago, actually did look at the urinary excretion of potassium, and this is a surrogate for the intake of potassium, and found that there was an association of a lower blood pressure, associated blood pressure with a higher potassium intake, even though you take into account all the confounders. And then with a increase of 30 to 45 millimoles of potassium a day, we can reduce our blood pressure by 2 to 3 millimeters of mercury. So lots of evidence came up that potassium is inversely associated with blood pressures, unlike sodium. But of course, the other question we want to ask ourselves is, does potassium intake protect you from developing hypertension? And there was a study, the PREVENT study done in the Netherlands. It's a longitudinal prospective study of normotensive individuals at baseline. And what was found is that it is the median amount of potassium they were taking. If you were taking a higher potassium diet, your risk of getting hypertension is far lower than those who were taking a low potassium diet. So this again shows the evidence of the protective effect of a high potassium diet. And again, just looking at the reduction in blood pressure that one would get with an increased potassium diet is that the overall population, you can get about 3.5 millimeters. Normotensive individuals, probably not much to reduction, but in the hypertensive individual, if you were to increase your potassium intake, you can reduce blood pressure by about nearly 6 millimeters, 5.5. And even more important is that if you are on a high salt intake, more than 4 grams, and most countries eat more than 4 grams, you potentially, by eating more potassium, get a reduction of nearly 7 millimeters of mercury. So again, very important in terms of being able to reduce blood pressure. And of course, whether increased potassium intake does reduce cardiovascular events. This is a meta-analysis that was done, and it showed that in terms of stroke, there was a risk reduction in developing stroke. Although the quality of the evidence was not very good, it was that there were lots of participants in this meta-analysis. Unfortunately, coronary heart disease and all-cause death did not quite come out positive. Be that as it may, the WHO, based on all the information that is available, strongly recommend a daily intake of 90 millimoles of potassium a day to try to reduce blood pressure and the risk of cardiovascular events. This is a paper we just published, but if we look at the potassium intake in developed countries as well as many countries in Asia, where the recommended is 90, we can see no country achieves that target. Perhaps UK and Korea do a little bit better because they are eating 70 millimoles of potassium a day compared to others who are eating less than half of it. In fact, a recent systematic review and meta-analysis of the 24-hour urinary sodium and potassium excretion that was done in China showed that basically potassium intake was less than half of what is recommended, and sodium intake is approximately double that of the recommended levels. And so therefore, I think this applies to many countries. We are in a situation of a high sodium and a low potassium intake. So that brings us to the question of which is more important, which should we be considering? Is it the sodium or the potassium? I don't have time to share with you the individual data, but to just summarize what is out there, and that basically it is not just the sodium intake alone, but also the potassium intake that is associated with elevation in blood pressure. And therefore it was proposed that instead of looking at sodium alone, potassium alone, is to look at the sodium to potassium ratio, because it's been found to be a better indicator of the high sodium, low potassium diet that we all consume. Not only that, both the systolic and diastolic blood pressure was strongly associated with the sodium-potassium ratio, and that it is a better marker than sodium alone or potassium alone in relation to blood pressure outcomes and incident hypertension. And of course, importantly, again, blood pressure reduction was larger for the sodium-potassium ratio than for the sodium or potassium alone. And again, when we look at the sodium to potassium ratio in many parts of the world, again, ideally it should be less than 1, but of course I think no one can achieve that. Again, looking across all the countries, the ratios are in a way quite alarming, some going up to about 5 ratio of the sodium to potassium ratio. So the situation now is that we know that a high sodium, a low dietary potassium is associated with elevated blood pressure, associated with worse cardiovascular outcome, and that reducing salt intake, increasing potassium intake can reduce blood pressure, can reduce cardiovascular events. The question is, why not do both? Why not decrease sodium and increase potassium? And this is where salt substitution is an attractive and viable option. Salt substitute, basically what it does is just replace some of the sodium chloride of regular salt with potassium chloride. And there are actually many types of salt substitutes. There's potassium citrate, potassium magnesium citrate, and many, many others with flavoring as well. Obviously, whether this works or not, there were RCTs that were done, and the meta-analysis again shows that with potassium supplementation in various percentage did reduce blood pressure by about 5 millimeters systolic, and it was greater in individuals with hypertension, 6.8. And this is exactly what we saw earlier in the figure that I showed you, and that the meta-regression showed that both daily potassium intake and decreased sodium to potassium ratio is associated with blood pressure reduction. And of course, a big study that showed the use of salt substitution, this of course was done in China, the very famous SAS study, which included people from many villages, adults who are older with hypertension or stroke. They were randomized to receive either a salt substitute, where the salt was replaced with 25% potassium chloride, or the regular salt group. And the primary outcome was to look for major cardiovascular events and death from any cause, keeping an eye on safety because of the risks of hyperkalemia. 21,000 people were involved in this study. It ran for 4.7 years. And indeed, we can see, like the earlier data, about 3.3 millimeters lowering of systolic blood pressure. Obviously, the amount of sodium that is excreted is less. They're eating less. This in the intervention group compared to the control group. Potassium excretion is more because they are eating more potassium. And this was translated into reduction in all the cardiovascular outcomes, strokes, major cardiovascular events, death. And this was done safely, fairly safely, in the sense that there was no signals of any hyperkalemia. That is one study, but there are other studies that have done salt substitution on cardiovascular events. This is again 23 RCTs on about 32 people. Again, exactly the same findings. All-cause death was reduced. Unfortunately, cardiovascular death just missed the point of significance, but the trend is there. And again, done with no safety issues in terms of hyperkalemia. Nevertheless, hyperkalemia is a potential adverse effect in the salt substitution. So therefore, as doctors, we need to pay a little bit attention, particularly in those who have chronic kidney disease. Those are taking potassium-sparing diuretics, for example, spironolactone, even the RAS blockers. Potassium salt tends to have a little bitter taste. It is more expensive than regular salt, and that's why the manufacturers are sort of objecting to salt substitution, because the cost can be double or sometimes as much as 14 times the regular salt. The salt substitution study, of course, also looked at cost effectiveness. And indeed, what they found is with the stroke reduction and more QALYs that they get, it is actually very cost saving and very cost effective. In terms of policy for potassium intake, there is none except for the WHO's recommendation. There's no policy in the world that talks specifically about potassium for reducing blood pressure. Of course, there's none in Asia Pacific. And all the hypertension guidelines just give a general recommendation in terms of a diet high in fruits and vegetables without saying anything more, without saying what the amount, without saying what it does to the blood pressure. And I think it's time to have some policy where we could advocate and in fact push very much for increased potassium intake besides the sodium reduction that we are doing, and perhaps even mandate and implement the use of salt substitution, because I think that is one of the ways to go. And so in summary, successful reduction of hypertension and cardiovascular mortality and morbidity requires not only sodium reduction, but requires an increase in intake of potassium. And it is this balance between the sodium and potassium intake, what we will call the sodium-potassium ratio, that is more important than either one alone. And therefore, I think the use of salt substitutes could be a way to try to reduce sodium intake and decrease potassium, to be done simultaneously. With that, thank you for your attention.